Right now, millions of people over 60 are waking up every morning, swallowing their blood pressure pill with a glass of water and trusting that what they are doing is protecting them. And most of the time it is. But there are 3 specific blood pressure medications. Medications that are prescribed every single day in doctors' offices all over the world. Medications that most people have been taking for years without a single question asked. And they have a hidden problem that almost nobody is talking about clearly enough. They are slowly, quietly, and in some cases permanently damaging your kidneys. And here is the part that should alarm you. It does not hurt. There is no pain, no signal, no warning. Your kidneys lose function in complete silence until the damage is already serious. And once kidney function is gone, it does not come back. I want to be very clear about something before we go any further. I am not here to scare you away from your medication. Blood pressure that is not controlled causes far more kidney damage than any medication we are going to talk about today. So please do not stop anything you are taking after watching this. What I am here to do is give you the information you need to walk into your next appointment and ask the right questions. Because that conversation, that single informed conversation with your doctor, could protect your kidneys for the rest of your life. Stay with me all the way through, because the 3rd medication on this list is the one nobody sees coming. And it may be sitting in your medicine cabinet right now. Before we get into it, drop a comment and tell me where you are watching from. Your city, your country, wherever you are. I read every single one, and I want to know who this community is made of. First, let us talk about why this hits people over 60 so much harder than everyone else. It is not just about the medication. It is about the kidneys you are bringing to the medication. Here is something most people are never told. After the age of 40, kidney function naturally declines by roughly 1% every single year. Just from aging alone. No disease, no damage. Just time. By the time you are 65, you may have already lost 20 to 25% of the kidney function you had in your 40s. Not because anything went wrong, just because that is how kidneys age. Now think about what that means. Those kidneys that are already working harder to do the same job they used to do with full capacity are now being asked to handle powerful medications that affect blood flow, fluid volume, and internal kidney pressure every single day. And unlike a younger person whose kidneys have full reserves to absorb the stress, your kidneys at 60, 65, 70 are working with a much smaller margin. Which means the same medication that a 40-year-old handles without any problem can cause measurable permanent damage in someone over 60. That is not a flaw in your body. That is just the reality of aging kidneys meeting adult medication. And the only way to manage it safely is to know what you are dealing with. Type margin in the comments if nobody has ever explained this to you before. Because this is the foundational piece that most people are never given. Now let us get into the 3 medications. Medication number 1, diuretics. You may know them as water pills. The most common ones are hydrochlorothiazide, furosemide, and chlorthalidone. If you are not sure whether you are on a diuretic, look at your medication name. If it ends in those letters, or if your doctor ever described your pill as a water pill, this applies to you. Diuretics work by telling your kidneys to flush out extra sodium and fluid. That reduces the volume of blood circulating through your vessels. Less volume means less pressure. And that is exactly how they lower blood pressure. They genuinely work. They are well studied and widely used for a very good reason. But here is what almost no one explains at the pharmacy window. When your kidneys are being constantly told to push out more fluid, they need adequate water to do that job without stressing the tissue. And here is the problem. Studies show that up to 40% of adults over 65 are already mildly dehydrated on any given day. Not severely dehydrated, mildly, chronically, without even knowing it. So you have kidneys that are already aging, already slightly reduced in function, already mildly dehydrated. And now you are adding a medication that tells them to flush out even more fluid every day. Think of it like an engine running low on coolant being asked to climb a hill. The engine still runs, but the stress on the internal components is quietly building up. And over months and years, that stress accumulates into something the doctor eventually calls chronic kidney disease. Now, here is the thing about diuretics and dehydration that makes this even more dangerous for people over 60 specifically. As we age, our thirst sensation becomes less reliable. A younger person gets thirsty. They drink. The problem corrects itself. But older adults often do not feel thirsty until they are already significantly dehydrated, which means by the time you reach for a glass of water, the damage from that day is already done. The fix is not to stop your diuretic. The fix is to drink water whether you feel thirsty or not. A consistent minimum of 6 to 8 glasses per day. Not when you feel thirsty. On a schedule, like taking your medication. Type water pill if you are on a diuretic and your doctor has never had a specific conversation with you about how much water you need to drink while taking it. Because that conversation should have happened, and for most people, it never does. Medication number 2, ACE inhibitors. Lisinopril, enalapril, ramipril, benazepril. These are some of the most prescribed medications in the entire world. Millions of people over 60 take one of these every single morning. Cardiologists love them. Internists prescribe them routinely, and for most people, in most situations, they are genuinely beneficial. ACE inhibitors work by relaxing blood vessels throughout the body. They reduce the resistance the heart has to pump against. They lower blood pressure. And in certain kidney conditions, particularly early diabetic kidney disease, they actually protect the kidneys by reducing the pressure inside the tiny filtering vessels. So ACE inhibitors can be kidney protective for the right patient in the right situation. But there is one specific situation where they become quietly dangerous. And it is more common in people over 60 than most doctors routinely screen for. It is called renal artery stenosis, which simply means a narrowing of the arteries that supply blood directly to the kidneys. Now, here is the critical thing about renal artery stenosis. It causes 0 symptoms. You will not feel it. You will not know it is there unless someone specifically looks for it. And it is significantly more common in older adults, particularly those with a history of cardiovascular disease, high cholesterol, or long-term high blood pressure. Here is why it matters with ACE inhibitors specifically. Your kidneys depend on a certain internal blood pressure to filter properly. Think of it like water pressure in a hose. You need enough pressure for water to push through. ACE inhibitors reduce blood pressure throughout the body, including inside the kidney vessels. For kidneys with wide open, healthy arteries, that reduction is manageable. The kidneys adapt. But for kidneys fed by narrowed arteries, already working harder to pull blood through a restricted opening, reducing that pressure further is like kinking the hose on top of the narrowing. Almost nothing gets through. And without adequate blood flow, those kidney filters cannot do their job. Every day that passes without enough blood reaching those filters, more microscopic scarring accumulates silently. Let me tell you about a man named Robert. He was 67. He had been on lisinopril for 2 years. His blood pressure was controlled. He felt completely fine. He was doing everything right. But At a routine blood test, his creatinine had risen and his estimated kidney filtration rate had dropped from 78 to 59. His doctor investigated. He had moderate renal artery stenosis that had never been detected. Nobody had ever looked for it. The lisinopril had not caused the narrowing, but it had been quietly stressing those narrowed kidney arteries for 2 full years without a single symptom to warn anyone. His medication was carefully adjusted, his kidney function stabilized, but those 2 years of silent decline could not be undone. Robert did not do anything wrong. He took his medication as prescribed, he went to his checkups, he felt fine, and his kidneys were still being affected. The screening test for renal artery stenosis is called a renal Doppler ultrasound. It is non-invasive, it is not painful, it checks blood flow to your kidneys directly. If you have been on an ACE inhibitor for more than 6 months and nobody has monitored your kidney function through a creatinine and GFR test, that needs to change before your next appointment ends. At your next visit, say this: "Doctor, I have been on my ACE inhibitor for a while, and I would like to check my creatinine and GFR to make sure my kidneys are handling it well. Can we also discuss whether a renal Doppler would be appropriate for me?" Write that down, screenshot it. That question takes 30 seconds to ask, and it could change what happens to your kidneys over the next 5 years. Type ACE if you are currently on lisinopril, enalapril, ramipril, or any other ACE inhibitor and have not had your kidney function checked in the last 12 months. You need that test. Now, medication number 3. And this is the one that will surprise you the most, because it is not a blood pressure medication at all. It is ibuprofen, naproxen, aspirin at high doses. The same pain relievers that have been sitting in your medicine cabinet for years, the same ones you reach for when your knee hurts, or your back aches, or you wake up stiff in the morning. These are called NSAIDs, non-steroidal anti-inflammatory drugs. And on their own, for a healthy person with healthy kidneys taking them occasionally, they are generally fine. But here is what turns them into a kidney threat for people over 60 who are already on blood pressure medications. NSAIDs block substances in the body called prostaglandins. Prostaglandins have multiple jobs. One of those jobs is to help maintain blood flow through the tiny vessels inside your kidneys. When NSAIDs block prostaglandins, those kidney vessels constrict, blood flow drops, filtration drops, waste starts to back up. On its own, for a short time, a healthy kidney can handle that. But now imagine you are also on a diuretic that is reducing the fluid volume available to your kidneys. And you are also on an ACE inhibitor that is reducing the blood pressure inside your kidney vessels. And now you add an NSAID that is constricting the blood vessels themselves. 3 separate mechanisms, 3 separate drugs, all hitting the kidneys from 3 different directions at the same time. Kidney specialists actually have a name for this combination. They call it the triple whammy. And the research behind it is sobering. A study published in the British Medical Journal found that taking an ACE inhibitor, a diuretic, and an NSAID together doubled the risk of acute kidney injury. Doubled. In adults who had been managing their health in perfectly reasonable ways. And nobody planned this. Nobody sat down and said, I am going to take 3 kidney damaging things together. What happened is exactly what happens in real life. A cardiologist prescribed the blood pressure medication. A general practitioner prescribed the diuretic. And the person picked up ibuprofen at the grocery store because it always worked for their arthritis, and nobody told him it was now a different situation. 3 different decisions, 3 different providers, 1 silent problem building inside the kidneys for months and years. Type triple in the comments if you are currently on a blood pressure medication and you also take ibuprofen or naproxen regularly for pain. Because this combination is far more common than most people realize, and it is far more dangerous than it looks. The solution here is not to endure your pain without treatment. The solution is to swap to a safer alternative for daily use. Acetaminophen, which most people know as Tylenol, does not have the same prostaglandin blocking effect on the kidneys. It is generally much safer for people over 60 who are also on blood pressure medication. Topical NSAIDs like diclofenac gel, applied directly to a painful knee or shoulder, are absorbed locally with far less impact on the kidneys than a pill that goes through your entire system. Talk to your doctor about which alternative fits your specific situation before your next dose of ibuprofen. Now let us talk about the question everyone always asks. How would I even know if this were happening to me? The honest answer is that you probably would not from how you feel. Kidney disease in its early and middle stages is almost completely silent. No pain, no dramatic symptoms. By the time you notice persistent swelling in your ankles, unusual fatigue that does not improve with sleep, or changes in how often you urinate, you have typically already lost 30 to 40% of your kidney function. That is not a small amount. And what is lost does not return. The only way to catch this while it is still early enough to matter is through a blood test. Specifically, you need two numbers. Your creatinine level and your eGFR, which stands for estimated glomerular filtration rate. Your eGFR tells you exactly what percentage of your kidney function is currently intact. An eGFR above 90 is considered normal. Between 60 and 89 suggests mild decline. Below 60 indicates moderate chronic kidney disease and means your kidneys are working at less than 60% of their full capacity. Below 30 is serious territory that requires urgent specialist attention. If you are over 60 and on any blood pressure medication, you should be getting this test at minimum once a year. Not because something is necessarily wrong, because catching early changes gives you time to adjust course before the damage becomes permanent. If your doctor has not ordered a comprehensive metabolic panel, which includes creatinine, in the past 12 months, ask for one before you leave your next appointment. Say exactly this: I would like to check my creatinine and my eGFR to get a baseline on my kidney function given the medications I am on. Can you order that today? Save this video right now before you keep scrolling. You are going to want these exact phrases before your next appointment. Comment checking if you are going to ask your doctor about your kidney function at your very next visit. Comment monitoring if you already get regular GFR tests done. And comment sharing if you know someone over 60 who is on blood pressure medication and needs to hear this today. I read every single comment, and I genuinely want to know where this community stands. Now let us talk about what you should actually do starting right now. Not after you think about it, right now. The first thing is to find out what medications you are actually on and which category they fall into. If you are on hydrochlorothiazide, furosemide, or chlorthalidone, you are on a diuretic. If you are on lisinopril, enalapril, ramipril, or benazepril, you are on an ACE inhibitor. If you are on losartan, valsartan, or olmesartan, you are on an ARB, which is a similar class to ACE inhibitors with many of the same considerations. Write down everything you take: prescriptions, over-the-counter pain relievers, supplements, everything. And bring that complete list to every single medical appointment you have. Because the dangerous combinations we talked about today almost always happen because no single provider has the full picture at the same time. The second thing is to drink water consistently throughout the day, whether you feel thirsty or not. If you are on a diuretic especially, hydration is not optional. It is part of how you take care of the organs that medication depends on to work. Aim for 6 to 8 glasses of water spread through the day. Not all at once. Consistently. The third thing is to address your pain through safer alternatives. If you are over 60 on blood pressure medication and taking ibuprofen or naproxen regularly, speak to your doctor before your next dose about switching to acetaminophen or a topical option. This single change removes one of the three components of the triple whammy entirely. The fourth thing is to get your kidney function tested. Creatinine and eGFR at minimum once a year. If you have not had it done in the last 12 months, call your doctor's office today and ask if they can add it to any upcoming blood work, not at some future appointment, today. And the fifth thing is to ask about renal artery stenosis screening. If you have been on an ACE inhibitor for more than 6 months without any kidney monitoring, ask whether a renal Doppler ultrasound is appropriate for you. It is non-invasive, it is not painful, and it answers a question your kidneys cannot answer on their own. None of this requires stopping your medication. None of this requires ignoring your blood pressure. All of it simply requires being the most informed version of yourself walking into that appointment. Type steps in the comments if you are committing to at least one of these 5 things this week. Tell me which one you are starting with. That kind of accountability matters, and it helps me know what to cover next. Let me close with something I want you to hold on to. Your kidneys have been filtering your blood every single minute of every single day for your entire life. Half a cup of blood every minute, every hour, every year. They have never taken a day off. They have never asked for anything. The fact that kidney disease so often goes unnoticed is not because your body failed to send signals. It is because we were never taught what signals to look for. We were never told to ask for the right tests. And we were never given the information clearly enough to know that what sits in our medicine cabinet, prescribed in good faith by doctors we trust, can sometimes be quietly working against the very organs it depends on. You now have that information, and information is the only thing that changes the conversation you have with your doctor next week. If this video helped you understand something you did not know before, please give it a like. It helps this information reach the people who need it most. Share it with someone over 60 who is on blood pressure medication, with a parent, a sibling, a friend. They deserve to know this as much as you did before you watched it today. Subscribe and hit the bell. We cover kidney health, blood pressure, blood sugar, and the hidden risks that do not show up in a 7-minute appointment, all in plain language that actually makes sense. And comment below right now. Tell me when the last time your doctor checked your kidney function was. Was it within the last year, 2 years ago, longer than that, or has it never been done at all? I want to know what is actually happening out there, because your answers shape the videos this community needs next. Your kidneys are still working for you right now. Every second. It is time to start working for them.